answers to these questions that I was sent in, and feel free to interact and ask questions if something's not clear or you want clarification or expansion on something. So they're all good questions. They had me thinking a bit, some of them. So the first one is, which countries have entry restrictions or bans? And do you have to declare your medication? If I'm traveling with people I don't know, I don't want to end up in a tricky situation at immigration. So this is a bit less relevant right now, unfortunately, with not much travel. But it is a really important thing to think about medications when you're traveling, and have plenty for a trip with you. And I always think it's better to have them in 2 bags in case one bag evaporates for whatever reason with all your pills. It's less stressful if you've got another little supply in another place. And it's good to have a letter from a healthcare professional stating that they're your medications and that you require them and mustn't be separated from them. And regarding declaring medicines and actually entry into different countries, there is, I saw general advice about travel on the Body Positive site. I couldn't actually see it on Positive Women's. You might also have it too. I'm not sure, you know.
Yeah, we do have a little,
Yeah. I couldn't find a search feature on it, so I didn't find it. But anyway, I just, travel has, on the Body Positive, has a useful page with countries categorized as red, extreme restrictions, orange, some restrictions, and green, limited or no restrictions. And there's also a link there that can be followed to a global database, or people can just find the global database by typing www.hivtravel.org. And that database has a drop-down box for every country, and it states clearly their regulations regarding entry into the country, whatever category it is, tourist or work or long-term. And so that gives guidance about entry restrictions or whatever. But once if you are free to enter, then you don't have to declare your medications. There are limits to how much people can take. Generally, when they, you can't take sort of a year's supply into most countries. Our country wouldn't want us to either. So there's just sort of a duration issue. But for moderate travel, you don't have to state that you're taking things. And, provided you're allowed into that country, you should be allowed your medications. So that was that one. Then, oh dear, I've got this so minimized I can't. Anyway, so the next one is, why do women living with HIV have the same doses of HIV retroviral medications as men? Can this increase the possible side effects for women? And I was thinking, I can't really think of any medications that are prescribed differently for males and females, whether it's antiretrovirals or other medications. I mean, some of you might think of some, but I can't. There are differences based on weight for a few medications, like, efavirenz. If somebody's under 40 kg, they'd get a smaller dose of efavirenz, 400 milligrams instead of 600 milligrams. And then occasionally we make adjustments if somebody's got renal impairment, the kidneys. So if the kidneys are the important route of excretion of a medication, you might give a smaller amount of that medication if their kidneys aren't working so well. But really, there's not many gender dosing differences, although there are a lot of theoretical reasons why it may be sensible. And it's an area that probably needs more research, the different ways women and men handle medications. There's a lot to the metabolism and absorption of pills that needs to be thought about. And unfortunately, as far as antiretrovirals go, many of the studies over the years have been performed predominantly in males, particularly in countries like America. You see the studies are often sort of 80% plus performed in men. So women have been traditionally underrepresented in HIV medication studies, which is unfortunate, but it is something that's been actively trying to be more balanced nowadays in research, just to correct that. And one thing about adverse events or side effects that this question alluded to, we do know that females in the general population, nothing to do with HIV, do experience more side effects than men for a variety of drugs. And so it is an important area that needs to be thought of about more in general, not just for antiretrovirals. So next is New Zealand's looking to vote whether to legalise cannabis. Some women living with HIV smoke cannabis to help with medication side effects or other conditions that they have. How harmful is cannabis, say, compared to cigarettes? So cannabis use amongst people with HIV is common. In a recent study of more than 3,000 patients receiving HIV care in 4 cities in America, 24% reported marijuana use in the past 3 months. And in comparison, in a national study of adults aged 26 or older in the general population, they're 5.6% reported use in the past month. So one is a 3 months and one's a 1 month, but they're quite big differences, 24% versus 5%. And in the large multi-site study of HIV-infected adults enrolled between 2003 and 2007, evenly 25% met the criteria for a lifetime marijuana use disorder. So although the active ingredients of the cannabis plant differ obviously from those of the tobacco plant, each produce evidently around 4,000 chemicals when smoked, and many of those chemicals are identical. So according to the American Lung Association, no matter the source of smoke, it's harmful to lungs. So whether it's from wood or tobacco or marijuana, smoke has multiple toxins and cancer-causing substances that can result in long-term breathing issues and eventually the development of lung cancer. So dope smokers tend to inhale more deeply and hold their breath longer, which results in a longer exposure to tar, a toxin from the smoke. And in addition, some research indicates that the smoke may potentially have more toxins of carcinogens than cigarette smoke. So potentially could be causing more lung damage just based on the smoke of it. And not only does smoke increase the risk of lung cancer, it damages little things in our airways, little beating fronds basically called cilia that trap particles and viruses and bacteria and move them back up so we can cough them out. And those little cilia are damaged by smoke, whatever the cause. And so with smoking, you increase risk of infections with damage to those airway linings, and so more likely to get chronic and acute bronchitis and sputum production and wheezing. And there's very little information that I could see about the effects of marijuana use on heart problems. We know that smoking cigarettes is bad for our blood vessels and increases the risk of heart attacks and strokes, but I couldn't see much information about that. Marijuana certainly can have effects on the brain, impaired memory and thinking, delayed brain development in younger users, and the potential for psychosis and depression and anxiety. And so I found one report looking at studies about memory effects of cannabis in people with HIV, which showed that HIV and cannabis use can both be associated with memory impairment. And the duration of HIV and the frequency and duration of cannabis use both increase the risk of memory impairment. And memory impairment from cannabis was greatest in those who started at a younger age. And heavy users who began smoking in adolescence can continue to experience prolonged memory impairment even a year after stopping, whereas among less frequent, well, people that started using it at an older age, the cognitive functioning can restore in several weeks. So it's particularly worrisome if young people start using it. There is a study that showed a benefit for painful peripheral neuropathy, and we do need to have more information about the effects of it, whether it could affect viral load suppression and things like that. There doesn't seem to be much published stuff about that side of things. So I think the referendum really is about whether to legalise cannabis because, I mean, it is available, obviously, but just because it's legalised doesn't mean it's safe. We know that cigarettes are not safe, and we know that alcohol often isn't safe, but they're legal. So, there's different. It's a different issue: safety and being legal or not, basically. So another referendum question. If the end of life bill becomes legislation, can a woman living with HIV exercise their right to die? And if so, when? And I would say definitely no. And to fulfill the criteria to be able to exercise your right to die, if the bill becomes legislation, a person must meet all of the following criteria. So they must be over 18 years of age and be a citizen or permanent resident of New Zealand. They must suffer from a terminal illness that's likely to end their life within 6 months, have significant and ongoing decline in physical capability, experience unbearable suffering that cannot be eased, be able to make an informed decision about assisted dying, and they would not be eligible if the only reason is that there's a mental disorder or mental illness, disability, or advanced age. So those are the criteria. So I think the answer is definitely no, purely on the basis of having HIV infection. HIV is not likely to end people's life within 6 months in this day and age. It's treatable and it may be curable in the next decade. I think it could well be. There's a lot of work going into cure. If the bill was legislation in the 1980s and early 1990s, some patients may have met the criteria then. However, I can think of quite a few patients who are alive and well now, who may have, had that bill been legislation then, may have chosen to end their life and missed out on 30 plus years of life. So it does, thinking about it does show to me the difficulties around this bill, basically, because things can change. And just thinking about the difference between the 1980s with living with HIV and the current time has clearly shown that to me. So it was a good question, but difficult issue. Now, the next question I've read is that recent studies have shown that HIV in women start perimenopause and ultimately menopause earlier. Is this true, and how much earlier? So just to define menopause, menopause is the cessation of menses or periods in a woman for more than 12 months with symptoms suggestive of menopause, so things like flushes and night sweats, and in which other causes of the period stopping have been ruled out. So there could be, other causes. And so a Canadian study published last year with 229 women living with HIV, so not a really big study, but a study, showed the median age of menopause of the women living with HIV was 48 years, which was 3 years lower than the average age of menopause in the general Canadian population, which is 51 years. And 30% of the women living with HIV had experienced menopause under 45 years of age, and that compared with 5%, so 30% versus 5% in the general population, and 14% had menopause less than 40 years, compared with 1%. So quite big differences in the early times for menopause. And there is similar data from Brazil, Thailand, and Nigeria. So why might this be? First, women living with HIV may have a higher prevalence of factors that are associated with early menopause, nothing to do with HIV, such as in this study, African or Caribbean ethnicity, substance use, hepatitis C infection, and smoking. And that was definitely the case in the Canadian women living with HIV. 65% of them had a history of smoking, 56% had ever used recreational drugs, 40% a history of injection drug use, and 40% a history of Hep C co-infection. So quite different from women here. Secondly, there may be some contribution of HIV itself and or the therapy, although this relationship hasn't been consistently identified. The Canadian study didn't find any relationship between clinical HIV factors such as CD4 count or having an undetectable viral load or use of antiretroviral therapy and the early menopause. Some older studies did find low CD4 counts among women predisposed to early menopause, but others didn't find that association. And this, of note, this Canadian study, all the nearly all the women had very well controlled HIV infection. 95% were on antiretrovirals with 87% undetectable viral load. Only 7% had a CD4 count less than 200. So they were very, as far as HIV factors go, they were very all homogeneous or similar to each other. So to identify reasons for low menopause from that group amongst HIV factors, it was difficult. So it is, I was thinking, after thinking about this, it might be something interesting to study here because, you know, we don't know. And I'm sure others, some of you would be interested in that.
Yeah.
So the next question is, if I have an undetectable viral load, does that mean I can take an HIV test for a new insurance policy and it will be negative? Well, that's a very sensible question, but the answer is definitely no. There's two different sorts of tests being used. The viral load is a test looking for the virus in the blood, while the HIV test that's used to diagnose HIV is an antibody test. So it's looking for things called antibodies that somebody manufactures in their body when they meet an infection. So in this case, HIV. The antibody test will always be positive once somebody has been infected with the virus, even if the virus is extremely well controlled and undetectable in the bloodstream and the viral load is negative. So you will never lose your positive antibody test. And diagnostic tests, the antibody tests are very, very cheap. The HIV viral load test is a very expensive, tricky test to perform in the lab. And so diagnostic tests will always be the cheap and easy, reliable antibody test. So unfortunately, there's no way around that. But healthcare insurers should be mindful of the fact that somebody's viral load is undetectable, because at the end of the day, that's really what matters now. And it's good. So the next question, I've heard it's harder for a woman to pass on HIV to a man than it is for a man to a woman. Is this true? And if so, why is that? Well, that is definitely correct. So studies show that in high-income countries, prior to the introduction of combination therapy, the risk per sexual act was 0.04 if the female was HIV positive and the male negative, but the risk was 0.08, so about half the risk, if the male partner was positive and double the risk. The female was 0.04 compared with 0.08 if the male's positive, so double the risk. So that sounds very low, I know, but rates were much higher if the source partner was either very early infection, when you have a high viral load, or late stage HIV, again with a high viral load, or if either partner had a sexually transmitted infection, especially one that caused genital sores. And also rates of transmission were much higher in studies done in low-income countries. So this difference in transmission risk is due to a number of factors. Compared with the penis, the amount of tissue cells susceptible to infection and damage are higher within the vagina. So the shaft of the penis is covered with skin that you know is pretty durable and protective, compared with the inside of the vagina that's got a lot of cells that are unprotected and very vascular during sex, lots of blood flow there. And so it's just really the tip of the penis that's more sensitive, and particularly in uncircumcised men. So the other thing is a woman can take in lots of semen into her vagina and it comes in contact with the cervix that's very vulnerable and can just sit there for a prolonged period of time. The presence of bacterial vaginosis is increases the risk of a female acquiring HIV, and rougher sex, and particularly if there's vaginal dryness, may lead to vaginal or penile damage, which increases the chance of infection if there's actually breaks in amongst the tissue. And reduction in vaginal lubrication, which is more common with age, probably increases the risk in postmenopausal women, because you can get more damage. And then younger women very early in puberty may make less vaginal and cervical secretions. So again, that probably increases their vulnerability to HIV. And we know that young teenage girls in Africa have very high rates of HIV. And circumcised men have a lower risk of getting HIV than uncircumcised men because the tip of the penis becomes tougher and more like skin there over time. So it's more sensitive and fragile and easier to infect if it's covered up by the foreskin in uncircumcised men. And of course, the best way to lower infection risk is to have all those with HIV diagnosed and on treatment with undetectable viral load. So all these other things don't really matter if you've got an undetectable viral load. Yeah. So this person says, I'm lucky to make my HIV specialist appointments. I don't ever see my GP. It's just not a priority for me. Can I still talk to my HIV specialist about things that are worrying me? Well, of course you can talk to your specialist about things that are worrying you. That's what we're there for. But we aren't GPs, and we don't do what GPs do nearly as well as they do. They're very good at doing things like blood pressure checks and treating high blood pressure. So I believe it's much better to have a GP as well as a specialist. I think we're complementary. We can do different things better. They can give vaccinations and do smear tests, etc., which can't be done at the specialist clinics. And another thing is that you already often have a lot of issues to discuss with your specialist appointment. And so there may not even be time to talk about some other thing that you could easily deal with at your GP. One thing that during COVID, we started doing quite a few of our follow-up appointments on the telephone. And going forward, we might do that more often now. Some of our specialist appointments might be by phone, so you might alternate a phone one with a face-to-face, phone one face-to-face. So you will be, if that's your choice, and a lot of people did find it more convenient not having to travel to clinic, it means you may be seeing your specialist face-to-face less often, and so how can things like blood pressure or weight be checked? So that's a further reason for maintaining contact with a GP. So I know appointments come around quickly. We're very mindful of that, but I think they do have benefits. Both sorts of appointments have benefits. Now the next question is, my boyfriend and I had unprotected sex after we both drank too much, and he has since had a cold and said he doesn't feel very well. Have I given him HIV? Well, I think your boyfriend should get a test as soon as possible if there's any concern about infection. But if you have an undetectable viral load and no genital infections, then the risk of infecting him is tiny or non-existent. If you don't have an undetectable viral load, maybe going forward, he should consider taking pre-exposure prophylaxis. If you and he are having sex when you're not fully suppressed. Seroconversion illness, if that's what you're worried about, typically starts 10 to 14 days after infection and lasts about 1 week. And common symptoms are things like fever, rash, tiredness, sore throat, and swollen lymph nodes. And it might be like influenza or often like glandular fever. And it can be quite mild or really severe. So there's a big range, and a lot of people don't have any seroconversion illness. But I definitely hope you can get your boyfriend tested and then think about going forward to try and avoid this concern again. But as I say, if you're on good antiretrovirals, the risk is nothing really. But always good to get tests. So the next question is, I'm currently on dolutegravir and want to get pregnant. I have read that pregnant women shouldn't take dolutegravir. Should I change my medication before falling pregnant? Well, in 2018, preliminary data from a study in Botswana identified a higher risk of infant neural tube defects. The neural tube is a little row of cells that form in the very tiny embryo that eventually form the spinal cord down our back. And neural tube defects can cause things like spina bifida, where the spinal cord isn't formed properly, and an infant might have problems with the control of their lower legs and their back be open even. So there was an increased risk of neural tube defects in women taking dolutegravir when they became pregnant. The risk was still low, but it was 0.94%, so nearly 1% of women's babies on dolutegravir had neural tube defects. So this led to us all thinking that women who wanted to become pregnant should not use dolutegravir. But then last July, so the first results came out in 2018, but then last July, more information became available with more women who had taken dolutegravir. The neural tube defects in this larger number of pregnancies showed that the risk was lower than in that initial study. It was lower than previous, but it was still slightly increased compared with women not taking dolutegravir. So in the bigger number of women, the risk was 0.3, so 3 out of 1,000, compared with people who were not taking dolutegravir or were HIV negative was 0.08, so 0.08 compared with 0.3. So there were 2 more neural tube defects seen per 1,000 if women were on dolutegravir at the time that they became pregnant in the first 28 days of the pregnancy. So there's been no increase seen in women who started dolutegravir in pregnancy after they were diagnosed, as the neural tube is all formed by 24 days. So because of this updated data, and because it does seem to be a small increase in risk, not as big as we had at first thought, and because dolutegravir, so the risk is small and dolutegravir has a lot of advantages, like it's once daily dosing, being pretty well tolerated and getting very rapid and effective viral load suppression, which is important during pregnancy. Dolutegravir is a preferred drug for those going on to treatment during pregnancy, but it's called an alternate antiretroviral for women who are planning to get pregnant. So an alternate one is one that you can use, but it's probably not the best idea. So I think in your case, it might be, I mean, certainly you can discuss it with your doctor, and it's over to you really. The risk is small, but there is a slightly bigger risk if you stay on dolutegravir before getting pregnant than if you swap to something like raltegravir until, you know, after 12, from before you get pregnant until about the 12th week of the pregnancy, you could swap to raltegravir. It's still a very effective drug. It's in the same class as dolutegravir. Its main disadvantage is that it's, well, traditionally been twice a day, but now you can take it once a day. So the other thing is, so once, you know, later in pregnancy, after 24 days, it's fine to go back to dolutegravir. But of course, you want to be on medication before conception because, you know, you want to have a fully suppressed viral load. But it might be better not to be on dolutegravir when you're planning to conceive. It's really important for anyone planning to conceive to be on folate. Folate dramatically reduces the risk of neural tube defects across the board, whether you've got HIV or not. And if someone is planning to stay on their dolutegravir when they become pregnant, they should have a higher dose of folate than the normal dose. So that is something to think about if you decide to stay on dolutegravir while getting pregnant. So the next question is, what harms and benefits does the syrup given to baby after birth have, immediate and long term? Well, the use of antiretrovirals during pregnancy reduces the risk of infection of the baby while it's in uterus and at the time of delivery. And giving the infant a little bit more for 2 to 4 weeks after delivery reduces the risk of the baby having infection acquired during the birth process. So it's kind of post-exposure prophylaxis for the baby for the actual delivery. So the treatment that you're on during pregnancy is really important, you know, to stop the baby getting infected in the uterus and lowers the risk of infection at delivery. But just belt and braces, I guess it is to give the baby a little bit more medication for 2 or 4 weeks, depending on the baby's risk after delivery, just as a kind of post-exposure prophylaxis. And it seems to be pretty safe. It's been used widely now. We've been using AZT in pregnancies since, well, early 1990s, and there don't seem to be any long-term harms. There have been reports of mild, brief rises in something called lactate in babies and infants who've received nucleoside reverse transcriptase inhibitors, so AZT or zidovudine is one of those. The relevance of those brief elevations are unknown. And then there are always, there have been reports, rare, of developmental delay, seizures, and other neurological disease. However, we don't know if the actual zidovudine was the cause of those. So I would say that I think the benefits outweigh the small theoretical concerns of harm. So another birth one. I'm anxious to think about the fact my future baby may not have a completely natural birth and be breastfed, though I have undetected HIV in the bloodstream. I have had mixed opinions and it has unsettled me greatly. And I'm sure this is a really stressful, and I agree, getting mixed opinions must make it very hard. And you know, mixed opinions because I don't know, it's, you know, it's perspectives basically. Some people think just do the absolutely safest thing. Some, you know, and you can go to the other extreme and think, well, it's a small risk, so we'll do whatever I want. But it's different viewpoints from different people, of course, mean that you get different messages. And at the end of the day, I think you have to make your decision, informed decision. Nowadays, a birth can, I think, be very, very close to natural or virtually natural if the mother has been on effective antiretrovirals during the pregnancy and has had viral loads below 50 or during, you know, several times during the pregnancy, including one after 36 weeks, so close to delivery. There's no reason for things to be done differently during the birth, really, or to have, certainly not to have a cesarean section. The only difference, I believe, would be the zidovudine to the baby that we just talked about in the first few weeks. And women can choose to breastfeed if they wish, although because it's not completely free of risk of transmission, our New Zealand guidelines and the British HIV Association and the American Academy of Pediatrics all recommend bottle feeding rather than breastfeeding. In countries unlike ours that don't have fresh water and reliable formula, exclusive breastfeeding is encouraged because that's safer than getting terrible gastroenteritis things from unclean milk. But we know that if a woman who's on antiretrovirals who doesn't breastfeed the infant and the infant's not infected at birth, the infection rate will be 0 moving from the birth onwards. But if they do breastfeed, there is a small risk, 0.3% to 0.7% of mothers who are on good antiretrovirals can infect their babies if they are breastfed. So it's very small, but it's not as safe as formula, which is no risk of the mother transmitting it. Now, obviously, the risk to the baby of catching it would be much higher if the mother did have a detectable viral load, and then that really would be discouraged. So the risk of an infant getting infected during breastfeeding is increased if the mother has a low CD4 count, evidently. The longer breastfeeding carries on, you know, it gradually goes up with time, the risk. If there are any breast abnormalities, such as mastitis or nipple abnormalities, if the baby has lesions in the mouth, like ulcers, and also a mixture of breastfeeding and formula feeding in the first few months of life, compared with only breastfeeding, seems to increase the risk, as does abrupt weaning. So if somebody does breastfeed, they should have very regular viral load checks, maybe monthly, and the infant should too. And also the infant should have them at 4 and 8 weeks after breastfeeding is stopped to check just in case they were infected. And finally, we don't know the effects of the triple antiretrovirals absorbed from breast milk by the baby. That's not really been thought about. One thing that it's worth remembering is that some women have unfortunately transmitted HIV to their baby, it is thought, through chewing up food in their mouth and then giving it to the baby, pre-mastication. So that isn't a good idea. But it's a hard area because the risk is small, and I really appreciate it's hard. The next question is along the same lines. It says, is it absolutely necessary to continue giving baby syrup if breastfeeding? I think the longer use of medication, from what I can tell, is recommended if a baby's born to a mother with a raised viral load at birth, or if a mother is breastfeeding without a suppressed viral load, which really isn't sensible, I don't think. So I'm not sure where somebody, what somebody's experience is with giving it longer than 2 to 4 weeks, which would seem uncommon to me. So I'm sorry, I'm not too sure about that one. And the next question is about smear tests. Does it have to remain compulsory for people living with HIV to have a smear test every year, even if for the last 10 years results have been normal and they've not been sexually active? Well, unfortunately, women with HIV have increased rates of human papillomavirus infection and an increased risk of cervical lesions and more rapid progression of lesions to cancers. And that's why the recommendation is to have annual smears, even if they've been consistently normal. Your word compulsory, I wouldn't have thought that it should be considered compulsory. I mean, it's recommended, but I think it's your choice, and you actually can't be forced to have a smear if you don't want one. But I know it's tempting to stop, but it's probably a good idea still. There are changes to smear tests coming in here in the next few years, when the way that smear tests is done is going to be quite different. At the moment, smears, somebody looks down the microscope to look for abnormal cells in the specimen that's taken from the cervix. That's called cytology. But we're going to change, hopefully in the next year or so, to doing a completely different test, and that is just a swab for the serious human papillomavirus types. So type 16 and 18 are the serious ones. So if somebody, people will need smears probably less often, and only those with wart virus of certain types identified will need to get more regular checks. So the screening programs will change soon, probably. And how that will impact on those with HIV, I think if you never have the HPV, the human papillomavirus identified, then maybe you could, not have smears. But at this point, we're still doing cytology, which is looking for the downstream effect of the abnormal viruses. And it might develop after a long time, even in someone who's not currently sexually active. If they've had the wart virus sitting there, it could be dormant and still cause problems many years later.
Oh, sorry, Joan, I realise that you're probably running out of time now, but there
are... Oh, sorry.
No, there's a few questions in the Q&A. Can you see?
Where's that? No?
Down the bottom, the Q&A.
Sorry, I timed it yesterday and it was 36 minutes.
No, that's fine. So people have been asking questions in the Q&A rather than...
Oh, right.
Yeah, can you see it?
Yes, yes. So would taking it in oil or eating it in cake? I
think that's to do with
cannabis. That's cannabis, yes. So cannabis has effects on the brain, as you know, and so it's not going to have the harmful effects on the lung, obviously. So that gets around the lung smoke inhalation issues, taking it other ways, certainly. And can the medication for HIV affect your sex drive? Basically, many things can affect sex drive, and medications of various sorts can. Things like antidepressants are very well known, some of them, for affecting sex drive. Without looking it up, I I'm not aware of any HIV medications affecting it, but I guess I would say they could do, but you know, anything's possible.
Yeah.
On that one, yeah. But they're not particularly known for it, like some drugs are. Do you want to stop now, or?
It's up to you. Do you have more questions that you'd like to answer, or?
Well, there's, I think, about 1, 2, 3 more questions.
Sure.
4.
Okay, let's do that.
I don't know.
Yeah, no, that's fine.
Any other questions on things I've talked about? I'll just look at the chat. Oh, Marina. Since people living with HIV need to maintain healthy dentals, any chance of a government subsidy or discounted rates? Well, that would be lovely. But no, I think there is a scheme through Body Positive, and I don't know again if Positive Women are involved with that, where I think for people on benefits there may be some sort of a arrangement that can be made. And then something that's new is that the University of Otago Dental School in Dunedin, well, it's always been in Dunedin, but now they have students coming up to a big clinic in South Auckland, and you can get cheap dental care provided by the dentistry students if you live in South Auckland. So that is something for some people. And I also see the Green Party promise free dental care to students, beneficiaries and pensioners if they get in. So. The next one is, have there been any reports of body pain in people living with HIV that are on emtricitabine, tenofovir and dolutegravir? And definitely trials have shown a small percent, like 3 to 6% of those taking emtricitabine, tenofovir can develop pain in the back or muscles. And although it wasn't reported in studies of people taking dolutegravir, it has been noted since it became widely used, very uncommonly to cause pain. But as I say, it wasn't seen in the trials. But so either of those drugs could be causing pain. Then the next question is, what is known about leg pain and antiretrovirals? So there's much research being done into leg pain. It's very often due to something called peripheral neuropathy. So that's damage to the nerves going down to the feet. That can occur in a number of illnesses such as diabetes, but also in HIV, particularly untreated HIV. The HIV virus itself can contribute to peripheral neuropathy, but also some of the early antiretrovirals we used to use, DDI and DDC, also contributed to it. We don't use those now. And so it's less common now than it was. But interestingly, chronic pain is a common disorder amongst the general population. In one study in America, 11% of the population reported chronic pain, and it is more common in those living with HIV. So those with HIV can have nerve pain, as I mentioned, musculoskeletal pain, and something called multi-site pain. And chronic pain in any person starts with some initial injury or insult, and the perception of it is either in the peripheral part of the body or in the brain, and is very strongly received on an ongoing basis for whatever reason. And a study has shown that those with a detectable HIV viral load have greater pain sensitivity than those with a suppressed viral load, and that they in turn have greater pain sensitivity than those not living with HIV. So it's an important and difficult issue, and not necessarily due to the medications, and certainly needs more study. And I watched this talk about chronic pain in those living with HIV, and the speaker recommended a book called Manage Pain Before It Manages You by Margaret Caldwell. So I haven't looked at it, but it was really interesting to me that pain sensitivity is different, which is hard.
Yeah.
And finally, what effect does HIV have on the aging process? It's not yet clear to researchers clearly how HIV and the natural aging process interact, mainly because the first people ever to age with HIV are in the process of doing so now. And so debate exists as to whether people living with HIV are prone to accelerated aging, or and if so, who's most vulnerable and what causes it and what can be done to slow it down. So aging typically has loss of muscle mass, loss of bone mass, weight loss, memory loss, decreased kidney function, brain and heart function, poor eyes and ears, and decreased heart function and deteriorating immune system. But and many things impact on that, genetic and environment. And it isn't an easy question to answer because we see so many of these things with HIV, and you know, how much is aging and how much is related to HIV is still a big question. So I think a lot of research is being done on that. So I've just had a big birthday recently, so it's a bit of a depressing question, really. Any other questions?
Oh, here, I think we've got another quick Q&A question.
Most affected organs in the long run for what? I'm not sure what that question.
Are they intimating? Are they talking about age? Do you think?
Well, mate, just pretty much everything really, as I listed. Unfortunately.
Taking the art.
With that, side effect wise, because everyone is different. You know, some people get stomach problems, nausea and diarrhea and things like that, whereas some other people might get muscle aches. Yeah, so we do know though that taking antiretrovirals reduces inflammation in the body, and when somebody's not on antiretrovirals, they have much higher inflammation, and inflammation contributes to aging. So the main thing I think with antiretrovirals now is that there are good options, and if something is hard to take, then there are other options. You know, if you've got to take something long term, you don't want to be feeling ill or whatever from it. How will you tolerate taking it? So I think the important thing is to work with your doctor to try and find one that suits you ideally. So
I think that's it.
Okay.
Thank you so much, Joan. We really appreciate your time.
I hope it was helpful.
And have a wonderful day.
Thanks. Thank you. Oh, Jane, have you got a question? No. Oh, bye everyone. Have a good day to you.
Thank you.
Okay.
We appreciate it.
No problem.
Bye.
Bye.